Good afternoon, and thank you for joining us today. We appreciate your attendance as we host Dr. Beth Wolf for our clinical validation appeals and how you can establish a role for your CDI staff. We have a great session today, but just wanted to go through a couple housekeeping items. If you have any sound issues throughout the presentation, there is a dashboard that should be on the right-hand side of your screen. Just click on the audio section and check the setting. It might be your computer audio. If you are having issues with your computer, you can dial in using the call-in number and the passcode. Definitely ask questions throughout. Dr. Wolf is going to try to get to as many questions at the end as she can. And if not, if we don't get to your question, we'll certainly follow up with you after. But that is also in the in the question section of your dashboard, and then also in the handout section of your dashboard is a PDF of the presentation for today. We are going to be sending out an archive of the recording after, so you can listen again. And also at the end, you will get a certificate of attendance that will be emailed to you following. And then lastly, we certainly appreciate your feedback. So as soon as the webinar is over, it will automatically launch. And if you could fill out that survey, we would really appreciate your feedback on how we did today. So without further delay, I am going to go ahead and turn things over to Dr. Wolf to get things started. So thank you, Dr. Wolf. We appreciate it. And go ahead.
Excellent, Lisa. Thank you. Well, welcome everyone. I'm happy to be here to talk about one of the things I actually enjoy doing, which is sticking up for my physicians. My background is internal medicine and palliative medicine, and I currently am the medical director for health information management at Roper St. Francis Healthcare in Charleston, South Carolina. I also do some consulting work for 3M and have had an opportunity to visit sites that are also effectively utilizing CDI encoders for denial appeals, specifically clinical validation appeals. So I'm going to share with you some of the things that I've learned along the way, and I'm hoping that you'll post questions and also your insights and your experiences. And like Lisa said, if we don't get to all of the questions, I will be looking at them and beginning kind of a summary statement and response to those questions afterwards. So please give me your thoughts. So as I sat down to kind of prepare this talk, I mean, the depth and the breadth is so huge. This is loosely what we're going to be talking about, which is really just understanding why CDI encoders really should be involved in the appeals process in some way. I'm going to go through, some ways of looking at the chart and pulling out the things that can create an effective, articulate, and persuasive appeal. So as always, this is very practical information. You have a whole team of legal and compliance folks at your hospital, and certainly within the revenue cycle and the denials and appeals process. You want to make sure and always engage them in any kind of planning or changes in the workflow. So this is a little bit of review, but I think, especially when I talk to physicians, really just understanding how this even occurs. How do we get denials and why do we get denials? So we know that clinical validation is the process of just ensuring that a documented diagnosis is supported by clinical evidence. And usually when it's, not supported, oftentimes it's a typo or interjected in error. Okay, so again, we do this all the time. Okay, in order to write queries, we engage in this process. We look for appropriate clinical indicators before we ask the question. So, 3 reasons for me why I think it's important, and probably 6, the first 3 being integrity, right? We want our charts to be as accurate as possible, not just because of denial prevention, but of how we're going to use this data. The codified data is important in patient care, and I think, sometimes we lose sight of that. But if we're going to effectively make changes in our own internal processes, we need to understand the patient population. Okay, so I use the example of sepsis, right? I mean, how are you going to know if you're using your sepsis bundle appropriately and effectively if you don't identify all the patients with sepsis? Okay, if we don't identify them, we're not documenting it. The second reason, of course, is compliance. And, the CMS Medicare conditions of participation tell us that claims submitted must not include diagnoses that cannot be clinically validated. Now, there's a lot of gray in here, right? And physicians always ask me, well, what does the code book say it is? And I have to painfully tell them that, the code book is not a dictionary. It does not come with definitions of clinical diagnosis on how to interpret the documentation and what code it goes to, but it doesn't necessarily give us those definitions. It's more like a phone book rather than a dictionary. So, I think that one of the things that I struggled with when I first sort of learned about CDI and coding and documentation is that the reporting of these codes is in no way based on the clinical criteria, right? So again, that idea that the code book has lots of rules, but it doesn't have a rule about, what should be coded based on clinical criteria. So, when physicians ask my CDI encoders, how do you define that? They're like, well, you're the provider. How do you define it? And so, one of the challenges has been, gaining some consensus or some reasonable consensus around definitions and threshold criteria. Okay, and then why we're here today. Why else is clinical validation important? Well, obviously for payment, right? We want to be paid fairly. We don't want to go above truth, but we certainly don't want to go below truth, all right? And so, part of clinical validation is denial prevention, but the other piece of that, and I think that this is sort of that circular education that I got when I started this, is that, those queries that address clinical validation give us appeal power. And, I think that, the more evidence that I can present that the physician agrees with, makes the argument stronger. Okay, so and we'll talk a little bit about in the appeal process where, we can actually connect the dots and read between the lines, which is something we cannot do when we're actually coding the chart. Okay, so what does a typical clinical validation denial letter look like? Well, it usually says this is what we're denying, this is why we're denying it. Usually lack of supporting documentation, and then they do kind of summarize some of the things they found in the chart. And of course, they pick out the things that seem to negate the diagnosis most effectively. And of course, there's always a statement, there was insufficient clinical evidence and supportive documentation in the records available for review, okay? So that's going to be a key point, to substantiate the coding of this condition, therefore it will be removed. Occasionally it will be replaced, okay? So, they kind of toss in the things that make sense to them. Okay, so kind of laying the groundwork, I'd like to get a sense of who's out there listening. So can you go to the poll question, Lisa? And if you're talking, you might be on mute.
There you go. It has launched.
All right, so what we're asking here, just again, to get a sense of who's listening in, I want to know how many appeals you have actually written, okay? So none, that may be the answer for many of you. Less than 5, maybe you're pulled in just occasionally, okay? 6 to 10, 11 to 20, or more than 20. As a learner doing this is one of the first things I was asked to do when I started in this role. I got better at it, partly because I saw what worked and what didn't work. And also I tended to save my old letters because some of the evidence that I used was, the same argument in letter after letter. Okay, so, saving those references, saving those templates, it's much like a good query, right? You know it when you wrote it and you save that one, right? So this is very similar. So do we have the results?
Yes, we do. All right, so 44% said none. Less than 5 was 10%, 7% said 6 to 10, 5% said 11 to 20, and 33% said more than 20.
Okay, great. So we definitely have a wide range of experience. And that's okay, right? Because what I'm really here to talk about is why both CDI specialists and coders are really positioned well, to address these denials. And, whether you're already doing it, whether, you've just started the process, or you're at a program that, is thinking about it, or maybe you want to be involved with it. What I will tell you is CDI specialists and coders often possess the characteristics which I think really promote a successful appeal. First of all, clinically knowledgeable, and I include coders in that. I mean, the first person I worked with at my hospital on denials and appeals is a coder. We currently continue to work together. So sharp, and our workflow is that she kind of casts the first net and sends the first letter and wins many of those. Okay, so again, that clinically knowledgeable, and that comes from being in the records, all right, and seeing how physicians articulate their thoughts, because there's a recurring theme. Okay, many of the same diagnoses come under scrutiny over and over again. The second thing that you all have going for you is an understanding of the coding guidelines and the coding clinics. So this was the learning curve for me, right? I literally had to go and look up each one, that the denial letter put in there, to understand, what they were basing their denial on, if they were referencing a coding clinic. I still can't say that I have them all, memorized and ready to go, but I think being able to apply some of those rules on the fly, you can definitely, call them out earlier. Sometimes it took me a little longer to process that. The third typical characteristic is an element of curiosity. I think that just asking why would they write it like that? What were they thinking, right? Because providers don't always put down, on paper everything that's going on in their head, right? And, the common belief, and my common belief, is that the clinician at the bedside that wrote this diagnosis believed it was there. And I may not be able to see the evidence written out in black and white, but I'm going to go looking for some of the subtleties. The fourth thing is being confident. And by that I mean, being confident in what you know, but also being confident in what you don't know, and when you need to go look something up, or when you need to call the physician advisor or the physician involved in the case, right? Because again, for those of you who do it, it is not unnerving, but you have a sense that I'm putting my signature at the bottom of this letter. And so everything in here, I need to be, factual, that I would get up in front of my peers and feel comfortable reading aloud. The next bullet point, I think there's no lack of being detail oriented for most of us, right? I think that we are used to picking the clues and finding information, but I do also need to be big picture focused, because sometimes the payers can be very convincing in their letters as to why they don't think that the patient has the certain diagnoses. And it's easy to kind of go, oh, okay, well, the patient didn't have this and this and this, so they must be right, rather than stepping back and looking at the big picture and kind of, like I said, reading between the lines. And then number 6 is being articulate. And, even in my own provider notes, I tended to be a little bit verbose, and I've had to really work at that, work at including the pertinent things, but being brief. Okay, that brevity is important, because if the letter's too long, I get lost in what your argument is, and it really should be pretty clear why you think this patient met criteria for the diagnosis in question. And then there's one more typical characteristic, and I didn't put it on the slide because I wasn't sure that I wanted to own that later, but I think a healthy bit of cynicism can enhance your approach to these appeals. I mean, for those of you who do them, again, I try not to let my blood pressure rise when I get, upset that they're, denying my doctor this diagnosis and the patient this diagnosis that's still so clear to me. But, you do have to have kind of a little bit of a cynical thought in your mind to be able to, kind of process, well, why are they saying that? What are they trying to get to? Obviously, they're trying to, recoup money, and we want to keep it. So I didn't put that on there, but I do think there is a healthy element of that. Okay, so these are all different diagnoses that I have appealed over the years, and I'm sure there are many more. What I wanted to point out here, and you can see that the diagnoses with a single asterisk are CCs, and with a double asterisk are major comorbidities. And the way I've organized them, and this is the sort of the 3M APR-DRG risk assignment in terms of risk of mortality on a scale of 1 to 4. And, I think that what I don't want to lose sight of is that, certainly any diagnosis is fair game, okay, that increases reimbursement. And, in looking at kind of the impact of these, it's just not financial, okay? When they take back this diagnosis, certainly in a 3 or a 4, we're losing that risk of mortality profiling. No matter, kind of what your benchmarking tool is, most of these high value diagnoses equate to increased risk of mortality. So, what are the typical characteristics of diagnoses that are denied? Because obviously we, have thousands of patients with those diagnoses on the previous page. In my experience, the universal unifying theme is that removal from the claim or removal as a principal diagnosis, if they're arguing that aspect of it, decreases reimbursement. Okay, so that is the universal #1 risk, single CC, single MCC, or if you're on the APR-DRG payment system, a diagnosis that's going to move it from a 1 to a 2, 2 to a 3, or 3 to a 4. So as I mentioned, the unrecognized impact, not just risk adjustment, but as we move more from volume to value, we're seeing more in-depth and critical analysis of diagnoses that either can exclude you from certain quality metrics or are powerful risk adjusters in those metrics. So it's more than just financial impact. The second kind of characteristic of diagnoses that are denied include those with essentially kind of debatable clinical criteria, and nothing, of course, stands out more than sepsis 2 versus sepsis 3. And it's not just a payer issue. I think as clinicians, there is different schools of thought on which is the best approach to take. We all know that we need to be treating sepsis. The question is, what is the best way to diagnose it to result in the most matched treatment, okay? So debatable diagnoses or diagnoses that have not really been defined in the literature are often targeted. So again, things like encephalopathy, which if you look at the definition of encephalopathy in the neurology literature and delirium in the psychiatric DSM-4 literature, they're essentially identical or very close. Okay, so again, it can create a lot of gray for the payer to work within. The third kind of typical characteristic of diagnoses that get denied are this idea that the clinical significance is unclear, okay? And what are they looking at? Well, the same thing we might look at as a reader of a novel, right? If it's a main character in the book and it's only mentioned once, how are we going to interpret that? Are we going to think that, that's really a main character, or, what happened to them? So again, I think the meaningfulness with which the physician addresses the diagnosis, sometimes the frequency impacts that. So again, anytime we see things that don't kind of bring that main character to the forefront, we might see an issue with it. And then again, just simply, the clinical significance. There are some things that are very hard to treat, like hyponatremia in a heart failure patient, right? I mean, we know that's a sign for worse prognosis. We plug it into the Seattle heart failure prognostication model, okay? But if physicians aren't addressing it and they're not talking about its clinical significance, the payer is not sure that it contributed to the care that was provided during the admission. And then, the what I call the documentation red flags. And if you see me talk about actual clinical validation queries, and I'll have a slide coming up that shows that, but there are certain things, like things main character is not being mentioned in the discharge summary. It's not a deal breaker, right? The code book says we can code from anywhere in the chart, but the payer's like, if you didn't think enough to communicate it to the next provider of care, who most certainly is not going to read the last 20 days of notes, how important was it really? And of course, we're prepared to argue that, but that's the kind of sentiment that may come out in the denial letters. Conflicting documentation, well-nourished exam, malnourished patient. Okay, so they're going to capitalize on those red flags. And these are many of the reasons when we see these things within the record, we often have triggers to write a validation query. And again, certainly if it's a single CC or an MCC, or if the criteria are gray. So not a surprise here. So why do I also think that CDI and coders are in a prime position to do this? The value of education and really the opportunity to learn and then to educate. So, we talk about denial triage. I kind of put them into two buckets, all right? The diagnosis is valid, okay, meaning as a reader of the record, I think the patient has it, regardless of how it was documented, and versus not valid, which is, I can't connect the dots to make this seem like a valid diagnosis. So if we go down here to not valid, I do not fight those. I mean, I pay them back and I use it as an educational tool. I may, send an email to the physician. Now that may not be something that CDI and coders are comfortable with, but that's certainly a role of escalation for a physician advisor, right? To just say, hey, we got this. I couldn't find, any information to support pretty typical criteria. Please provide me, any additional feedback. And sometimes I even send that email before I agree to pay it back, just in case, they can give me additional information. Now, in the valid group, all right, kind of triaging that, there are going to be some that are well documented by the physician, okay? These are the ones that make your blood boil, right? It's wasting everybody's time. Obviously, we appeal those, and, depending on, your payer contracts, especially if it's a managed care payer, escalating that through your legal and compliance department, to make sure that egregious things are not happening within that contract language. And then, of course, probably the most common where the diagnosis is valid, but it's lacking really documentation by the physician. Okay, so that may mean that the indicators are in a non-provider's note, so the payer didn't see them. Whatever the case may be, that's an opportunity to appeal and educate, okay? And again, it may be physicians, it may be CDI, right? Because when we talk about documentation, obviously the physician is frontline, but our job as CDI specialists is to query, okay? And it may be not necessarily pointed education for the CDI, but maybe a program to look at, well, we're not covering the patients that we need to because we didn't even get a chance to see that patient as CDI. Again, so kind of keeping track of how we can be doing this better. Okay, so I promised I'd talk a little bit about kind of the approach to assessing clinical validity. And, this is very counterintuitive because I'm asking you to read between the lines, but as a sort of a translator to code, which obviously CDI and certainly coders' primary responsibility, we're really not allowed to do that. And I recognize that CDI specialists are doing that when they're formulating queries, okay? So it's a little more comfortable for the CDI specialists. But in my opinion, deciding to appeal is the single most critical step. And honestly, when you're looking at these charts, I really invest, the same amount of time, whether I ultimately decide to appeal or not, because I'm looking for information, right? I'm still pouring through the details of that chart. And essentially, much like that triage, I'm asking is, do we really have a legitimate case to argue? And you kind of have to go through all the steps to kind of get to that answer. And, this is sort of our standard internal approach to clinical validation, when we're concurrently reviewing, but it helps to kind of have that same process as I'm reviewing the denials for potential appeal, because I am looking for minimal diagnostic criteria, and especially I'm looking for exceptions to the rule. does the preponderance of treatment and assessment match that diagnosis, right? So if a physician diagnoses sepsis but never gives a fluid bolus, or doesn't get serial lactates, or doesn't get blood cultures, like that is inconsistent with how we typically manage sepsis, right? Am I gonna, point the finger and say that that provider did something wrong? No, this is for my internal sort of decision as to whether or not, to validate the diagnosis, or in this case, appeal it. I do look for contradicting documentation, and if there is any, I want to know if it's insignificant. Okay, meaning if I'm, looking at an acute respiratory failure case, and they had pneumonia and they were intubated, and I've got a note that inadvertently left no acute distress in it. Yeah, is it contradicting? But it's pretty insignificant given the scope of the treatment plan. All right, so I'm not worried about a payer calling that out. All right, so again, there's some common sense going on. And then contradicting documentation might have already been addressed. So for example, if I have acute tubular necrosis that I've documented, and I recognize that the fractional excretion of sodium is less than 2%, and that's not typical of ATN, but I've already said why I still think it's ATN. Okay, so it's been addressed. The consistent documentation, so again, this is sort of the concurrent validation process. It's not a deal breaker, but of course, that's sort of the meaningfulness of the diagnosis and clinical significance. And then, the last piece of it, did the provider, document some additional rationale? And sometimes this will be in a query, and queries don't usually get sent to payers, as part of the reviewable medical record. Okay, so again, that's another tool that we use, and certainly that I look for. One of the first things I look for when I'm going into a denial review. Okay, got another polling question here, so the 33% that write a lot of these will probably be able to answer. Other folks, make your best guess. Lisa, I'll let you go ahead and read that out.
All right, it is launched.
Perfect.
And go ahead.
Okay, yeah, no, I'm sorry. I have it in front of me. Sometimes it disappears. So I am allowed, as the appeal writer, hypothetically, if you're not currently writing them, to include the following as evidence in a clinical validation denial appeal. A, nursing and ancillary documentation. B, post-encounter information. Okay, so these denials can sometimes come a year after the patient was discharged, so there's an opportunity to see lots of information since the last admission or since the encounter in question. C, the pre-encounter information, okay, so the data leading up to the admission. Answer D, both A and C, or E, all of the above. So again, as you're answering that question, this is the kind of stuff that feels a little counterintuitive as certainly a coder and even a CDI. It wasn't until recently that kind of the AHIMA query writing brief gave us some wiggle room on pulling in information from a previous encounter that is relevant to the question being asked today. We can't just pull it in out of the blue. There's got to be something going on during this encounter, that makes that a valid clinical indicator to include. And most hospitals really have to write their own policy around that, or that's really the recommendation to make sure that they're following it consistently, and even setting up parameters for the types of things that they can be looking for. Okay, do we have responses back?
We most certainly do. All right, so for nursing and ancillary documentation, we got 16%. We only have 1% for post-encounter information, 2% for pre-encounter information, 38% both A and C, and all of the above was at 43%. And just real quick before I hand it back over, just a reminder, we are starting to get some questions in, so if you do have any, please make sure you add them throughout in the dashboard. And also, if you are wanting the handout of the PowerPoint, it is in the handout section of your dashboard. So I'm going to go ahead and hide this, and you are set to go.
Okay, perfect. So Yeah, so I wasn't surprised at the responses. Obviously in concurrent queries, we can include nursing and ancillary documentation. As I mentioned, the practice brief for letter C, kind of that pre-encounter information has, been allowed under certain circumstances. I will tell you that I selected E and how I currently write appeals because I take off the gloves. I wish I had a good picture of that to include. Kind of all bets are off if they're saying that my physician didn't make, a legitimate diagnosis. And so, I go everywhere. A lot of times I end up arguing that a diagnosis, let's just call out severe malnutrition, even though the patient was only in the hospital for 3 days before they were discharged to hospice, was still an important factor in medical decision making and the care plan that ensued to decide to go home with hospice. And if I happen to know that that patient died within the hospice enrollment timeframe, that is post discharge data, but I'm going to bring that up. I'm going to be like, it is a misrepresentation of this patient's overall risk of mortality to remove that diagnosis. Okay, so I do go there. If I'm trying to prove a baseline, okay, so sometimes you've never seen the patient before, right? The encounter in question is their first admission, and the argument is, well, you don't know that it was acute kidney injury, doctor, because we didn't see the baseline 1.5 times or 3 times, depending on which definition they're using, rifle or KDIGO. But if I can go forward, the lowest creatinine that they came down to, well, just like in the hospital, if it was the lowest creatinine, I'm going to say that's at least their baseline. Okay, so I do use all of those. Okay, so I think in terms of the practicality, and I kind of keep notes. I have a document saved for each patient with notes, and then I have obviously my final letter. But within the notes section, I really catalog kind of the supporting and also what I would say contradicting documentation, both in risk factors, indicators, the assessment and the treatment plan. And that again includes, nursing and ancillary notes. I do this because I'm gonna have to write a second letter, okay? And I'm gonna go back through and read it and see if I, forgot to point something out. And then if it goes peer-to-peer where I have to be talking to another physician on the line, I don't wanna be caught blind. I wanna know the arguments that they're gonna make that they haven't made already. Okay, so I wanna know what's in the chart that doesn't support it, all right? The other big thing on here, in the one of the first slides, I said, this is typical of a letter, right? So in the documents we reviewed or received. So one of the great tactics is to find something that was not made available to the auditor initially, right? Nobody likes to be wrong. I don't like to be wrong, right? But if I'm wrong because I didn't actually have all the information, it's a lot easier for me to admit that maybe I was wrong. Okay, I'm sure that's psychology that someone already figured out, but it was it was good for me to process that. So I look at prior encounters, pre-hospital records, as I mentioned, post records even. I'm very focused on ED notes if I can get any, nursing home notes, and then of course the auditors are not going to be seeing nursing and ancillary notes. They're not going to be seeing details of I's and O's. Even in like the laboratory reports. So, when we look at our data within the electronic record, we get to toggle through things. We get to pull up graphs and we get to see trends. When records often get sent to payers, it's kind of in like a PDF format. And so it really is like, even a 5-day hospital stay can be like over 100 pages. Okay, so just in terms of kind of the appeal and the actual letter, oftentimes I'll do screenshots, including, the patient's identifier, so that they can see that more easily and readily. Okay. Okay, so if this is the most critical step, as I mentioned, if you do all this legwork and it doesn't seem like you have a legitimate case, okay, regardless of how the physician documented it, if it does not look like it was there, pay it back. learn a lesson, talk to, give feedback, whatever you need to do. If the answer is yes, it's legitimate, you need to take it, all the way. And I say that, there are some that are kind of gray, right? I still appeal those. Sometimes I get the second denial, right? I always go back and I review my notes again because, sometimes just the lens with which I'm looking at it changes. And I'm like, dang, that was definitely valid. I did not think of it that way, and I'm gonna take it peer to peer. Okay, so a second set of eyes, even your own, after time, can create more ideas and information. Okay, so you've decided to appeal. This is sort of my little checklist. It only has to happen a couple times where you forget to do this, and you're like, oh. So this first one, confirm exactly what is being denied and why. So you'd think you would have done that on the first blush, but I've been burned before where I've gone down a path of validating this diagnosis and pulling all the information in, and they're not really looking at the clinical criteria. They're looking at whether or not it should be principal diagnoses versus something else. Okay, so then you gotta kind of regroup and think about it differently. I do look at their cited references if I can get to them. Okay, sometimes they cite things that I don't have access to. If that's the case, in the letter, I ask them to provide me with the details of that reference if it's going to be, a valid part of my argument. I do review national guidelines and scientific papers. When you start this process, collecting these is going to be probably very time consuming. As you do them more, you'll kind of have, your bank. I do try to argue based on those patient characteristics. So if they're talking about the clinical significance of malnutrition in a COPD patient, if that's my case, I'm going to go pull articles talking about malnutrition in COPD. Okay, I'm going to try to quote something that is specific to my patient scenario. And then, of course, I have multiple Post-its around my computer. I got my tip card up, right? As much as I would like to say that I have all these internal sort of threshold criteria memorized, I don't. Just know your internal clinical definitions or threshold criteria if they exist. If they don't exist, still within your CDI department, most likely you have a consistent way of approaching the validation of these diagnoses. Case connecting the dots, this first bullet point, this is going to be, where you spend most of your time. All right, because you can't get more consistent documentation. The chart's gone. Okay, so you're really going to be focusing on those criteria that were there and really connecting the dots to the diagnoses that your physician is trying to make. This is where, again, probably, more so than even in a validation query, I pull in, from the physician perspective, all the orders they wrote, okay? What were they seeing at the bedside? What exam findings? And then we have the luxury of that clinical outcome, right? So looking into the future. I will tell you, I've fought aspiration pneumonia by saying, well, you know what, they came back 2 weeks later or a month later or, 2 months later with the same thing and they failed their swallowing study then. So clearly they had a good moment on this swallowing study, but, it was a progressive process, right? So again, that clinical outcome we have the benefit of seeing. Some sort of pitfalls that I fell into that I'll share with you. I always wanted to prove my case based on our system criteria, and that's not a bad thing, but don't forget, to understand their criteria and win with their criteria if you can. Okay, because if you win using their criteria, they have to pay you, and if they don't, that's when you sort of escalate and point out, the hypocrisy, to leadership. So what's an example of that? I think acute respiratory failure, right? The P to F ratios, okay? Or even acute on chronic where you see, a 10 millimeter mercury drop in oxygen, PO2 or increase in PCO2 from baseline. Well, guess what? If the patient had a baseline, 2 months prior or into the future, I can level set with that, and I can show them that, being on, 4 liters, this admission actually did represent, a change in their PO2 to the criteria that you're deciding that you want. So again, when using their rules if possible. Again, our wheelhouse, understanding the coding guidelines and the coding clinics, right? Use them, all right? So principal and secondary diagnoses definitions, present on admission, signs and symptoms present on admission. It doesn't have to be documented on the day of admission. And even if the physician documents it on day 2 and you don't get a POA query because it looked like it was all laid out there, arguing, hey, this is why we thought it was present on admission. Obviously the entire encounter, which includes those EMS records, suspected diagnoses, that often comes up in a denial. You need to understand how to argue that point. I do this a lot because I'm not the coding expert, but, phoning a friend, kind of going, hey, what am I missing here, right? This doesn't seem like they're playing fair. What is it about this? And obviously you're looking at the coding clinics that they cite in the guidelines. And sometimes they're citing guidelines that just don't even fit with what's happening. So, I call that out too. Sometimes I'll even go peer-to-peer with a physician and I'll go through each one of them, right? Because sometimes there's 30. Which is ridiculous, but that might be playing equally ridiculous. In terms of the format, and there's many different ways to do this. So this is by no means the only way, but typically I try to restate in an abbreviated form what is being denied and why. Okay, I use their criteria. If I do, I lay it out point by point. Okay, so if they're saying that the acute kidney injury did not meet SOFA criteria, I'm directing my responses to each of those. Okay. I do add additional supporting factors, even if it doesn't, fall into what they think it should be. I think it's relevant, right? And I, keep talking about sepsis 2 and sepsis 3 because that's what we're seeing a lot of. But I personally, yes, SIRS, we send a lot of people home with an infection in SIRS from the ER, right? So what is it about this patient that raised eyebrows? Well, even though it's not part of the SOFA criteria, things like bandemia, elevated lactate, all those things, I do include, but I try to argue point for point what they're looking for. I also talk about sometimes what is not documented, and this is where, the clinical kind of experience comes into play, okay? And I think that just because the physician didn't link the organ failure to the sepsis, there is no other possible cause, okay? So, no other cause was documented, right? So again, feeling comfortable and confident to make the argument that way. Summarizing your opinion, okay? And again, I typically go back through and I try to make it shorter, okay? Because if they're really gonna read this letter, I like to keep it to a page. Sometimes that's not possible, especially if I'm including screenshots, but generally in the text, I like to keep it pretty succinct. I then at the end say I disagree, and that, I will continue to pursue if they persist in this line. And, I have some catchphrases that I use, and we've talked about, if removing this diagnosis is a misrepresentation of, the patient's overall condition and care provided, whatever kind of language you typically use, but pointing out that I disagree. So in the last couple of minutes, I'm just going to share some success stories. And, I think that, it's important to do that, right? Because this oftentimes feels very thankless and sometimes futile. And even as an appeal writer, sometimes I don't get feedback. And it's not because my team doesn't want to give it to me, my revenue cycle team. It's because, the payers don't always tell you that you want. They just simply pay you, right? So there's a lot of reasons why feedback is difficult. So in this particular case, so this was a patient who had a stroke after surgery, and the payer was not denying that the patient had a stroke, but they wanted to say that it was should be coded as a post-cardiac surgery stroke. So as I was reading the response to this, I think there were a couple things that stood out to me. Obviously, and I'll jump down here to point 3, details matter. Okay, so the CDI reviewing this chart felt very comfortable. I think this might have been in caps on the letter. Nowhere in the documentation does it state occurred post-op, okay, or due to, because the payer said it occurred post-op, right? So, astutely pointed right to the coding guideline that said you didn't, there's no link. I challenge you to find a link. So they didn't stop there. Okay, they said, well, wait a minute. I looked at the EKGs and it looks like there was some sort of atrial arrhythmia. I went back and sure enough, they had, atrial fibrillation. They'd been on Eliquis, which was stopped for surgery. Old EKGs were then brought into the appeal letter. Obviously, I said success. So it was 1, complication appropriately avoided. Okay, so again, payment was impacted, but think about the other things that we're protecting downstream. Okay. So this was one where we'd lost the first appeal, and I got a call, and honestly, I get a fair number of calls, and I remember talking about this patient, and based on that conversation, a second letter was written, and I just pulled out the key points here: risk factors, abnormal labs, rapid decline. So we talked about the fact that we're not going to have a lot of evidence because we transitioned to a comfort focus pretty quickly. So the correspondence, I love this. I disagree with your assessment. So we're saying I and we, all right? So owning, the review, owning the interpretation, and then of course giving the summary there. And, within this, just kind of pointing out, the clinical kind of research that goes into this, right? That's one of the things that really stood out to me. So looking up what are the signs of liver failure, okay? Listing those in the appeal letter, then one by one saying, how is it that our patient looked like this, okay? What was about their risk factors, their UA, frequent paracenteses, complaints of malaise, poor intake, hypoperfusion, okay, blood pressure was low, 99/56, okay, talking about laboratory findings, acknowledging they were not tightly followed because of the rapidness of decline. All right, so impressed with just how CDI and coders are able to really put the pieces together clinically, right? Not surprised, but just very articulate. And I think when you start doing these, you really, start to think more and more like the provider, like a clinician. And, kind of an added bonus or side effect is that I think that we get better at writing queries and recognizing conditions. And then this was another one. So I put success story because I cannot imagine that we're going to lose this. So yes, I'm going to throw down if it's upheld. Again, looking at the big picture, right? Researching, what it is about, acute heart failure that presents atypically. Citing this patient's risk factors from, a list, and we have up-to-date subscription in our hospital. So we're able to really, pull in kind of the most recent and thorough literature, pointing out of those what the patient has, talking about their diagnostic tests. So, BNP 8800, chest X-ray, interstitial edema, echo from before, negative fluid balance, this admission. Okay, so that's important because, the patient didn't get Lasix, which was one of the payer's arguments, right? So we're showing, hey, whatever we did, okay, resulted in diuresis. So again, you don't need to have Lasix to treat heart failure always. This is atypical, but certainly very valid. Acknowledging, right? I hear you. I did not see any diuretics either, but guess what? I went back and I looked at the EMS records. Okay, not only did EMS give a bolus and the ED, they went upstairs on a cardizem drip. Okay, aggressive blood pressure control was requested. And of course, the home medications that the patient wasn't taking were restarted. Patient story preserved in the codified data. Okay, so parting thoughts, and we'll take a couple questions. And I think Lisa has a couple of announcements. I know this sounds crazy, but yeah, review the entire record. All right. So just, start at the beginning, and that includes EMS if it's, something that could contribute to, but don't be limited by it. All right. So, that's the picture that they were presented with. Add something to it. And then, always, does the totality of the story support the diagnoses, right? So if the patient has an elevated bilirubin, we're talking sepsis, and maybe meets SOFA because you're not sure of the baseline, but looks great and goes home on day 2 on oral antibiotics, like, does the totality of that, support the severity of the diagnosis? Maybe it does, maybe it doesn't. Okay, but again, don't forget that you have the ability to step back and look at that. Okay, the obligation to find the details, but the ability to step back. The second bullet point, and this is why I think writing these appeals locally is helpful, right? Because these physicians, like, you are going to go to bat for them. Okay, I don't want to say fiercely loyal, but sometimes I feel like that. I'm like, this is crazy. Like, they work so hard, to document the things that we need them to document with regards to supporting information, and when they do, they still get denied. Right. So fighting, for them to not be denied in the future. Right. And, part of this is, if you don't fight these, they will keep coming. I mean, they will be very, aggressive. But I have noticed that, if you fight consistently the ones that are valid, possibly they move on to somebody else, and they don't send as many of those that are really, not questionable. Phone a friend. I do this a lot. And then probably the most important thing for the 44% on the line that, or excuse me, 33% on the line that are writing these consistently is figure out how you're going to give this feedback. And it may be that you're not comfortable directly contacting the physician, but whoever your champion is that's disseminating education, this needs to be a part of it. And it doesn't need to be an hour lecture. It can be a flyer saying, hey, be on the lookout. If you're documenting sepsis, link the organ dysfunction. Here's an example. Again, trying to make sure that we keep what we capture, essentially. So with that, I'm going to stop. And I don't know, Lisa, if you want to do the announcements and then questions, or vice versa.
Sure. So just incredible information and so much. We have a lot of questions. Some of them are pretty specific that I have a feeling you're going to want to look at and have the opportunity to kind of take a moment and pause to respond. So I am going to ask one broad question that I think would be a good kind of wrap up. But yes, to your point, we do have a couple of announcements. I am going to launch our last poll. So while we ask this question, you can, let us know if you are interested in learning more information about any of our products and solutions. We would be happy to follow up with you after with some more information. But if you would like to actually speak to one of our representatives during the survey, there is an opportunity to let us know that as well, where you would be followed up that way. So what you have in front of you will be an email with some information following up. But if you would like to speak to somebody specifically, let us know during the survey. So yes, let's do the broad question, and then we'll wrap things up. So from Kay Merriweather, what is the main documentation tip you would share with providers that can prevent denials?
Yeah, so the main tip I would say is utilize your assessment. I mean, I think what we've seen either perpetuated by the electronic record or lack of time is that once we've entered our diagnoses into the problem list and it blows into that bottom part of our assessment and plan, we don't actually have an assessment. We don't articulate the things we're doing and why. Okay, many medical records simply, just blow in those diagnoses at the bottom and then list the different orders that you made, unconnected to what the diagnoses were. So, I think, that would be probably my biggest suggestion. Okay, because sometimes I might be arguing things the wrong way. Okay, but I'm kind of putting my clinical mind in there after the fact, and so the more that they can talk about their thought processes, the easier it is for us to really glean kind of where they're coming from and the rationale for the diagnosis. And sometimes their position on the threshold criteria is going to be different than the payers and even within the system. And I think at the end of the day, you're the clinician, you make the decision, but if you don't document how you got there, I can't respond to that. I have to ask the question. Okay, I can't, make any assumptions about that. So I think that would probably be my number one thing, is to put more in the assessment, and maybe not pull in every single radiology report and lab value that you're not using to attribute to your assessment. That might be a big stretch. The other thing I tell physicians, just on that side note, if you've put in your HPI, kind of, a discussion of what's happening and some rationale, I don't ask people to repeat it. Okay, much like, if the physician, documents pneumonia and then gives me the specificity in their assessment, yeah, would I like them to put it on the diagnoses list? Sure, but I'm still going to code from that. So even if their rationale is in the HPI or some element of that, I'm gonna take that. Okay, it doesn't have to necessarily be in that assessment portion.
Fantastic. Well, again, thank you so much for the information today. Just as a quick wrap up, registration is open for our Client Experience Summit. And so, if you are a 3M customer, we welcome you to be a part of this virtual conference. We wish it was in person, but unfortunately, we are going to be virtual again. There is a document within the handout section of the agenda if you are interested in seeing that. But as a reminder, we will be sending an archive out after this with both the recording and the presentation, as well as links to register for the next webinar. And then again, if you could complete that survey, just so we know how we did. I have a feeling we're gonna get a rave review for you, Dr. Wolf. Again, it was fantastic, so we certainly appreciate it. And again, you will be getting that certificate of attendance. We don't actually give the CEUs, but you can provide that certificate to either a HEMA or ACDIS, and to get those CEUs. So again, we appreciate your time today, and we look forward to the next one. Thank you so much.
Thanks, everybody.